Let's get right into it. We're deconstructing the high-yield urologic oncology mechanisms and the exact diagnostic management steps you need for a top percentile score.
Module 1. Varicocele Hemodynamics and Tumor Thrombus. We're going to start by mapping out the foundational, completely disparate venous anatomy of the male scrotum.
All right, let's break down this anatomic asymmetry. The right gonadal vein drains directly into the low-pressure inferior vena cava. The left gonadal vein, though, drains perpendicularly right into the left renal vein. Now, this right-angle insertion creates a ton of mechanical resistance, making the left side highly vulnerable to entrapment and dilation of the pampiniform plexus. Clinically, this manifests as a varicocele. You know, that classic palpable bag of worms.
Notice the critical diagnostic divergence we have here. An idiopathic left-sided varicocele is super common in young men, and it classically decompresses when the patient lies supine. But, and this is a massive red flag, a new-onset, strictly left-sided varicocele in an older male that completely fails to decompress when recumbent, that is an absolute neoplastic red flag. It strictly indicates an obstruction of the left renal vein, overwhelmingly caused by a renal cell carcinoma tumor thrombus growing directly into the venous lumen. On the flip side, a right-sided varicocele is incredibly rare. If you see one, you should immediately suspect a direct IVC obstruction or an extensive retroperitoneal malignancy.
Let's move to our first integrated assessment to test your diagnostic sequencing based on these hemodynamic red flags. A 65-year-old male smoker presents with a new left-sided scrotal mass that does not change size when lying down. So, what is the absolutely most urgent next diagnostic step?
Let's systematically dismantle these distractors. Option 1, a scrotal ultrasound, is incorrect. Sure, it confirms a varicocele, but it completely misses that proximal obstructive etiology. Option 2, reassurance and elevation, is just plain dangerous. It totally ignores the neoplastic red flag. What about option 4? A scrotal biopsy is absolutely contraindicated here because of the high risk of seeding the retroperitoneum by disrupting those fascial planes. And option 5, serum tumor markers like AFP or beta-HCG, well, those are indicated for primary testicular germ cell tumors, not a varicocele secondary to an upstream mass. That brings us to option 3. An abdominal CT scan is the correct mandatory next step to evaluate the left kidney and renal vein for a renal cell carcinoma.
Moving into Module 2, renal cell carcinoma and paraneoplastic searches. Let's transition over to the pathophysiology of RCC, starting right at its cellular origin.
Take a look at this contrast-enhanced CT. It demonstrates an enhancing exophytic mass in the left kidney. This is classic for clear cell carcinoma, which, by the way, makes up about 80 to 90% of malignant kidney tumors. These actually arise from the proximal tubule epithelial cells. Histologically, these cells look clear because they're absolutely packed with abundant glycogen and lipids.
Now, RCC is notorious for its deceptive presentation. You might be looking for that classic diagnostic triad of flank pain, a palpable mass, and hematuria, but that is actually a late-stage trap. It only shows up in 5 to 10% of advanced cases. You absolutely must recognize that the vast majority of these tumors remain clinically silent, often just discovered incidentally on imaging for completely unrelated complaints. RCC really is the quintessential internist's tumor. It drives profound paraneoplastic syndromes by secreting ectopic hormones. For instance, ectopic erythropoietin, or EPO, causes a reactive polycythemia. Ectopic parathyroid hormone-related peptide, PTHrP, drives severe hypercalcemia by mimicking PTH and cranking up osteoclast activity. And finally, excess renin secretion can trigger refractory hypertension.
Differentiating these paraneoplastic surges from primary disorders is absolutely vital. In primary polycythemia vera, which is a myeloproliferative disorder driven by a JAK2 mutation, endogenous EPO levels are actually suppressed and low thanks to negative feedback. But in secondary polycythemia caused by RCC, you're going to find inappropriately elevated EPO levels directly secreted by the tumor, which is what's driving the absolute erythrocytosis.
Let's test this integration. A patient presents with progressive weight loss, a hemocrat of 58%, and a serum calcium of 12.1 milligrams per deciliter. What's the most appropriate next step in management? We really need to isolate the singular underlying pathology explaining this specific paraneoplastic overlap. Option 1. A bone marrow biopsy evaluates primary hematologic malignancies like polycythemia vera, but remember, PV does not cause severe hypercalcemia. Option 2. A parathyroidectomy treats primary hyperparathyroidism, which obviously won't cause a hematocrit of 58%. Option 4. Serial phlebotomy is just a symptomatic treatment for polycythemia, not a diagnostic step for the underlying etiology. Option 5. Sputum cytology targets lung cancer, and while squamous cell lung carcinoma can secrete PTHrP, it doesn't typically secrete EPO. Option 3 is the right answer. The simultaneous presentation of ectopic EPO and PTHrP strictly points to a renal primary, which mandates an abdominal CT scan.
Now onto Module 3, urothelial carcinoma and hematuria kinetics. We're going to contrast RCC against transitional cell carcinoma, or TCC. TCC is actually the most common malignancy of the urinary collecting system that encompasses the renal pelvis, ureters, and bladder. For this one, you have to identify distinct toxic exposures in the patient's history. Cigarette smoking is hands down the most significant risk factor. Then there's occupational exposure to aniline dyes, heavily used in the rubber, textile, and printing industries. This is highly tested. Finally, pharmaceutical triggers, specifically chronic exposure to the alkylating agent cyclophosphamide, will significantly increase TCC risk.
Right here, we establish the absolute defining clinical presentation. Painless, gross hematuria occurring throughout the entire urinary stream in an older adult dictates an epithelial malignancy. You must suspect TCC until proven otherwise. In stark contrast, painful gross hematuria, which classically presents with unilateral flank colic, strictly points to nephrolithiasis or stone disease.
Let's look at our final integrated assessment, combining occupational history with the painless hematuria mandate. A 70-year-old retired rubber plant worker presents with painless red urine and no cellular casts. What is the mandatory next step in diagnosis?
Let's validate the procedural mandate here. Option 1, isolated urine cytology, is incorrect. While it does have high specificity for high-grade tumors, its overall sensitivity is just way too low, and it often misses low-grade lesions. Option 2, a 24-hour urine collection, quantifies proteinuria or metabolic stone parameters, which is completely irrelevant for a suspected malignancy. Option 4, a renal biopsy, evaluates glomerular or interstitial disease, definitely not collecting system epithelial tumors. Option 5, empirical antibiotics, is inappropriate without dysuria or a positive culture, and it just delays the cancer diagnosis. Option 3 is correct. Any unexplained painless gross hematuria in a high-risk patient requires immediate direct visualization of the bladder mucosa via cystoscopy paired with a CT urography to evaluate the upper tracts. And with that, this simulation block is complete.